on two topics, xerophthalmia, vitamin A deficiency, as well as ophthalmia neonatal. So
One
to
second,
start with,
one second.
yes.
Okay, yeah, continue.
Okay. Okay. Xerophthalmia includes a spectrum of ocular disease which is caused by vitamin A deficiency, usually severe. It is a leading cause of preventable blindness in developing countries. It signifies the severity of vitamin A deficiency that causes significant morbidity and mortality from malnutrition and an increased susceptibility to mucosal infections. So, etiology of vitamin A deficiency, it could be roughly divided into three: reduced intake of vitamin A, an impaired absorption, and a reduced storage. So, reduced intake could be in case of inadequate food supply, chronic alcoholism, highly selective dieting, dysphagia, mental illness. Impaired absorption could include any GI causes like Crohn's disease, celiac disease, pancreatic insufficiency, short bowel syndrome, chronic diarrhea, inflammatory bowel disease, upper GI surgery, giardiasis, and a beta lipoproteinemia. And reduced storage of vitamin A can be seen in conditions like liver disease and cystic fibrosis. Even in cases of acute acute illnesses, it may also lead to a sudden depleting in the storage of vitamin A. So risk factors include living in an endemic area and an area prone to vitamin A deficiency. In patients having a low socioeconomic status, patients with malnutrition, maternal malnourishment could also be a risk factor because it affects the vitamin A concentration in breast milk. Zinc deficiency is also associated with vitamin A deficiency. As inadequate zinc, it can depress the hepatic synthesis of retinol binding protein, which is required for metabolism of retinol from the liver. Zinc may also play a role in the conversion of beta carotene to retinol. Also, coexisting measles or other respiratory and diarrheal illnesses are risk factors. So sources of vitamin A, we have animal-derived food as well as vegetarian food. And animal-derived liver and cod liver oil are major sources of vitamin A. As I said, liver is where the vitamin A is stored maximally. Also, dairy products, fish, cheese, and hard-boiled eggs are animal sources. Vegetarian foods include orange vegetables, usually containing beta carotene, green leafy vegetables, bell pepper, and broccoli. So recommended dietary allowance in children in age 1 to 5, around they require at least 200 microgram per day to prevent symptomatic vitamin A deficiency. In children older than 5 years old, around 300 to 900 microgram per day is required. For males and female, around 700 to 1000 microgram per day can be described. And in pregnancy, there's a slight increase in the vitamin A requirement, and lactating women also 1300 microgram per day is required. So the pathogenesis and ocular manifestations of xerophthalmia, there are, like I said, the three causes that lead to xerophthalmia, the vitamin A deficiency. Xerophthalmia is basically, we have a decrease in visual pigment because retinol requires vitamin A. And so the first symptom that might come is nyctalopia, night blindness. Then it can lead to keratinization, thickening, and non-wetting of the conjunctiva because the squamous metaplasia occurs in patients, and non-keratinized epithelium is converted to keratinized epithelium. So it will lead to conjunctival xerosis, dryness of the conjunctiva, and also pitot spots, which are triangular patches of foamy keratinized epithelium. This can also further lead to a goblet cell loss, and it will cause a decreased surface expression of mucins with a reduced tear production, which leads to corneal xerosis or dryness of the cornea. Further, this can aggravate to cause corneal ulceration or keratomalacia, which is basically focal melting, which can lead to complications like perforation, loss of the eye, and phthisis bulbi. Also, retinopathy can be seen where we have a yellowish peripheral dots are seen and decreased electroretinogram amplitude. So WHO, according to WHO grading, We have XN, which stands for night blindness or nyctalopia. The peak age group is between 2 to 6 years in children, and also in adult women it might be seen. The type of deficiency which can cause this is usually a long-standing deficiency, and night it is not a very blinding in nature. So X1A is the next category, which is conjunctival xerosis. The peak age group is again 3 to 6, and it is also because of long-standing deficiency. The next is X1B, which is Bitot spot. It is a similar etiology. Then corneal xerosis affects children between the age of 1 to 4, and it usually denotes an acute deficiency and also can be blinding in nature. And X3A indicates corneal ulcer, which is less than one third of the corneal diameter. So it's a similar age group involvement, and this time there's a severe acute deficiency which can cause this, and the consequences can be blinding. Same goes for corneal ulcer, the next grade, which is X3B, corneal ulcer or keratomalacia, which involves more than one third cornea. So a similar age group and severe acute deficiency can be seen. The next is XS, which is corneal scarring, which is a next result of corneal ulcer. And about the age of 2, usually children are involved, and it's a consequence of corneal ulceration. The next is XF, which is xerophthalmos fundus, and it can affect adults. That is the age group typically affected, and this can also be caused because of a long-standing deficiency. It's a not blinding consequence, and the occurrence of this is pretty rare. So, talking about each and every grade. So, in night blindness, like the name suggests, it's a defective vision in dim light or night brightness. It is one of the earliest manifestations. So, in children, it is difficult to actually detect this because they are not going to complain. It has to be the responsibility of the parents to check the different behavior of the child that can happen in the day and the dark. The child may be less active, maybe fearful, doesn't want to go outside. The night blindness, it is considered to be both a sensitive and specific indicator for serum retinol levels. The next grade, which is conjunctival xerosis, as you can see in the picture, the conjunctiva appears dull and dry with a slight wrinkling seen. There is also loss of goblet cells and insufficient mucin secretion, and it can be subtle and difficult to detect clinically. Patient might just complain of a dryness of the eyes. Then comes the Bitot spot, which is grade X1B. So collection of desquamated keratinized epithelial cells are seen, and it is seen as triangular patches of foamy whitish opaque deposits typically located on the bulbar conjunctiva near the limbus at the 3 and 9 o'clock positions. Usually it is seen on the temporal side. The next is corneal cirrhosis. So as you can see in the picture, the cornea appears dull and hazy, and it is because of drying of the cornea. It may initially present with bilateral punctate corneal epithelial erosions, and it can quickly progress to the stage of corneal ulceration. So if a patient with corneal cirrhosis comes, so up to this stage, a high dose of vitamin A supplementation can result in the full preservation of vision. So we can reverse the symptoms, whatever have appeared. The next stage we come to is corneal ulceration and melting. It has to be treated as an urgency. So keratomalacia or the melting away of cornea, it can occur by liquefactive necrosis. It is the most severe form of xerophthalmia. It can perforate and destroy the cornea in just a matter of days. A child who usually appears healthy but develops keratomalacia should be always questioned about a recent history of measles or diarrhea, which could rapidly deplete the already deficient vitamin A stores in such children. So, not all children come with a stage of night blindness. They can come with a severe stage as well. So, so we have to ask for a proper history in such patients. The next is corneal scar. So scarring is usually it's symmetrical and bilateral, and we can see since it's bilateral, we also have to rule out other causes of corneal scarring. Also, a xerophthalmia fundus, a prolonged vitamin A deficiency may lead to structural changes in the retina, and fundus changes appear as small, white, deep retinal lesions which are scattered throughout the posterior pole. So, diagnosis we can usually do on physical exam, asking a proper history. The patient will usually come with night blindness, or and a proper physical exam checking under the slit lamp. We can see with what stage of the cornea, what stage of xerophthalmia is present. Also, blood tests are going to be helpful in ruling out other diseases. So, serum vitamin A or retinol levels can be done. Usually, the reference is 20 to 60 microgram per deciliter is normal, but VAD related ocular symptoms have been shown to develop at concentrations below 10 microgram per deciliter. Also, serum retinol binding protein levels can be checked, and serum zinc levels can also be checked. Other testing like dark adaptometry and night vision threshold tests can be done. On electroretinogram, retinopathy from vitamin A deficiency is associated with a decreased amplitude. We can also do impression cytology, where conjunctival specimens can be viewed for the presence of goblet cells, and a decrease in normal amount is considered an effective measurement of vitamin A deficiency. Um, Liver biopsy is actually considered the gold standard for evaluating, but we never usually perform it outside of research setting due to procedural risks. So, differential diagnosis could include any parasitic eye disease, trachoma, or allergic conjunctivitis, viral conjunctivitis, any dry eye syndromes, retinitis pigmentosa, and other retinal dystrophy, which can also present with night blindness, and pingecula or pterygium, which can resemble Bitot spots. So management, keratomalacia, if the patient directly comes with this, it is obviously a medical emergency and it indicates a very severe vitamin A deficiency. So usually if the child, if it's a young infant between 0 to 5 months, the vitamin A dosage is 50,000. In older infants between 6 to 11 months, a 1 lakh international units dose is provided. In children, 12 months or more, and females 12 months or more up to 12 years, and 50 years or more, that is non-reproductive group females, we give a dose of 2 lakh international units. In women in the reproductive group with night blindness and or Bitot spots, we give a 10,000 international units every day, and or we can give a 25,000 every week for at least 3 months. In women with active corneal lesions, we give 2 lakh international units on days 1, 2, and 14. So in even children, we give the dose on the first day, the next day after, and a month after. So for prophylaxis of vitamin A, usually, vitamin A is provided in our national immunization schedule. So it is given on in 9 months, the dose being 1 lakh international units, and on 18 months and 6 months, so on and so forth, till the patient reaches about 5 years of age. And after from the 18th month onward, the dose is 2 lakh international units. So usually the dose is given orally, but in case of very cachexic patient with a lot of diarrhea, with GI complaints, and there's a suspicion of any GI problem, we can also give an intramuscular dose. But in that case, we just make the dose half and provide it in an intramuscular manner. We can also give a zinc supplementation along with that, and localized ocular treatment like intense lubrication, topical retinoic acid, and management of perforation has to be done. Patient education regarding what are the dietary sources to be provided can be also be done, and a large scale vitamin A supplementation can also be done. So this is all about xerophthalmia. Should I move on to the next topic, sir?
Yeah, can you mention about the oral supplements that we generally give? Which oral supplement is given? Aquasol A capsules are there.
Okay, okay. Yes, sir.
Aquasol A capsules. So it contains 25,000 units per capsule.
Okay, okay, sir.
And vitamin A injection in between was short. So only oral was available. So in that case, you have to give high dose of oral this thing, and oral is usually double the intramuscular dose.
Yes, sir.
Okay. Any other questions or comments? Dr.
Sir,
Seema madam is there. You can tell about corneal conditions.
sir, I had a doubt.
Yeah.
Sir, if the if suppose pregnant female is there and she has developed the xerosis, then how to adjust the dose because vitamin A is teratogenic, so how to
Yeah.
manage in that?
Yeah. Nilambika, any answer to that?
Usually we avoid in pregnant ladies, and we can provide around 20,000 international units after delivery, but during pregnancy, usually to be avoided.
Yeah. So generally, the regular supplements, lower amount of vitamin A supplements can be okay, but we don't give very high doses of vitamin A during pregnancy.
Yes, sir.
Okay.
Okay. Any other questions? And in case of keratomalacia, what are the usual signs?
There's thinning of the cornea can be seen on slit lamp, and
What is the typical site?
then uh, near the palpebral fissure lining central.
It's infranasal part of the cornea which gets involved commonly.
Okay, sir.
And what are others? This thing causes for childhood ulcers or ulcers in children.
Any infective causes, uh,
Okay.
trauma to the eye.
Hmm. Why ophthalmia, neonatorum, and the keratomalacia? How do you differentiate?
Yeah, ophthalmia neonatorum is usually infective, so there is going to be associated discharge and redness for the changes.
What is the common age for ophthalmia neonatorum?
It occurs in neonates
Yeah.
up to 28 days of life.
And about vitamin A deficiency?
This is usually in elder, more than infants, like 1 to 4 years of age, up to 6 years of age, and in
So
females.
in the first 6 months, generally vitamin A deficiency doesn't occur generally. Why?
Mm, Stores are present, sir. Um,
Because the
and
babies,
breastfeeding.
yeah, breastfeeding and babies already have got stores in utero for 6 months.
Yes, sir.
Okay. So unless there is severe maternal vitamin A deficiency, which is not very common, the baby will not develop with keratomalacia in first 6 months of life.
Yes, sir.
Okay. After 6 months, because the liver has depleted its vitamin A, and if the child is not getting adequate vitamin A after birth, then child may present with ophthalmia, keratomalacia. And also, you mentioned about measles and recent diarrheal history, because if there is
Yes, yes,
significant diarrhea and all, and liver stops getting vitamin A, and there is also depletion of vitamin A because the shading of cells from the intestine, then child may develop keratomalacia very quickly.
yes, sir.
Okay. So generally, even for breastfeeding mothers, vitamin A supplementation is continued.
Yes, yes, sir.
Okay. And for during before birth, like during pregnancy, generally low dose of vitamin A is given to mothers. I think all this is included in maternal health programs, national programs.
Yeah, yes, sir.
Okay, go ahead with the second presentation.
Yes, sir. So the next topic is ophthalmia neonatorum. So conjunctival inflammation developing within the first month of life up to 28 days is termed as ophthalmia neonatorum. Most common infection of any kind in neonates can occur in about 10%. It is a potentially it's serious nature, and both ocular and systemic complications may be present. The infection is transmitted from mother to infant during delivery. So causes could be basically divided into three: chemical, bacterial, and viral. Uh, Bacterial include Chlamydia trachomatis, which is the most common cause of ophthalmia neonatorum, Neisseria gonorrhea, Staph aureus, Pseudomonas aeruginosa, Streptococcus, and other also bacteria including Klebsiella proteus, Enterobacter ceretia, and Echinella corrodens. Viral causes includes herpes simplex virus. Risk factors include maternal infections harbored in the mother's birth canal or a maternal HIV infection, exposure of the infant to infectious organisms, increased birth weight, inadequacy of ocular prophylaxis immediately after birth, premature rupture of membranes, ocular trauma during delivery, mechanical ventilation, prematurity, poor prenatal care, poor hygienic delivery conditions, post-delivery infection due to direct contact with healthcare workers or by aerosolization, and a silver nitrate exposure, which counts as chemical cause. So the timing of onset is important because it might indicate what the cause is. Chemical irritation usually occurs in the first 24 to 48 hours and will last only for a few days. Gonococcal infection may be seen in the first week. Staphylococcal and other bacteria may be seen at the end of the first week. Herpes simplex virus can manifest from 1 to 2 weeks, and chlamydia affects usually between 1 to 3 weeks. So, installation of any prophylactic chemical preparation or parental symptoms of sexually transmitted infection, a recent conjunctivitis in close contacts, and features of systemic illness in the child can also be indicative, like if the child presents with pneumonitis, rhinitis, and otitis in chlamydial infection, or skin vesicles and features of encephalitis in herpes simplex virus. And disseminated gonococcal infection is relatively rare. So, prior persistent watering without inflammation may also indicate a nasolacrimal duct that is not yet open. So signs include, in case of chemical conjunctivitis, a mild conjunctival injection with accompanied by tearing, spontaneously resolving within 2 to 4 days is usually the presentation. In case the patient presents with mild hyperemia with scant mucoid discharge to eyelid swelling, chemosis, and pseudomembrane formation is usually seen with Chlamydia trachomatis infection. In gonorrhea infections, acute conjunctivitis, which can be associated with chemosis, severe lid edema, and mucopurulent discharge can be seen. Also, corneal involvement is the most serious complication, involving diffuse epithelial edema and ulceration that may progress to perforation of the cornea and endophthalmitis. Initially, a superficial keratitis gives the corneal surface a lackluster appearance, followed by a marginal and central infiltrate appear, which can then ulcerate and form a ring abscess. In herpes simplex virus infection, typically presents with a unilateral or bilateral lid edema, a moderate amount of conjunctival injection, and non-purulent serosanguinous discharge may also be seen. Vesicles on the skin surrounding the eye are very indicative of a herpes simplex virus infection. A corneal epithelial involvement with microdendrites or geographic ulcers can also be seen, as opposed to the typical dendrites which can be seen in viral infections. So, the differential diagnosis may include a dacrocystitis, congenital glaucoma, a nasolacrimal duct obstruction, preseptal or orbital cellulitis, congenital glaucoma, or infectious keratitis. So investigations that can be done include parental prenatal testing for sexually transmitted infection. Then nucleic acid amplification. So PCR can be done particularly for chlamydia and HSV. Gram and GIMSA staining can be done. Multinucleated giant cells may be present on gram stain in HSV infection. Standard bacterial culture and is usually done for other bacteria, whereas a chocolate agar or Thier Martin is much specific for Neisseria gonorrhea. For epithelial cells infected with HSV may show eosinophilic intranuclear inclusions on Papinicolos smear. Then conjunctival scraping or fluid from skin vesicles can be sent for a viral culture for HSV. Specimens should be taken prior to fluorescein installation if immunofluorescent testing is planned. So, prophylaxis can be done by a single installation of povidone iodine 2.5% solution, which is effective against common pathogens. Also, other agents like erythromycin 0.5% or tetracycline 1% ointment can be used. Silver nitrate 1% solution agglutinates gonococci and is still utilized in areas where gonococcal infection is common, but there have also been chances where silver nitrate has been associated with a chemical cause of conjunctivitis. It should be administered in conjunction with a single intramuscular dose of benzyl penicillin when maternal infection is present. So generally now we use either povidone iodine or erythromycin drop. So in for treatment management, chemical conjunctivitis, only supportive care is necessary. We can also use artificial tear drops for 4 times a day for a few days, and usually it will resolve within spontaneously within 2 to 4 days. So in case of mild conjunctivitis, mildly sticky eye is extremely common in neonates. Investigation in this is often unnecessary, but we can start a low intensity regimen with a broad spectrum topical antibiotics such as chloramphenicol, erythromycin, or fusidic acid ointment, which is adequate in most cases. In a moderate to severe presentation, a microscopy with gram staining alone is highly sensitive and will often provide with a working diagnosis. If the diagnosis is uncertain but chlamydial infection is a reasonable possibility, oral erythromycin can be commenced on an empirical basis after samples have been collected. If bacteria are evident on gram stain, a broad spectrum topical antibiotic like chloramphenicol, erythromycin, or bacitracin for gram positive, and neomycin, ofloxacin, or gentamicin for gram negative can be started, and until the sensitivity is available. Additional systemic treatment should be considered in more severe cases. In severe conjunctivitis or when systemic illness is suspected, it may also require a hospital admission. Samples should be taken for a range of investigations, including urgent microscopy and broad spectrum topical antibiotic like erythromycin has to be started. The ocular risk is usually most acute from gonococcal infection. So empirical topical treatment should cover this, and in most cases, consideration given to systemic treatment such as parenteral ceftriaxone can also be done. In case of chlamydial conjunctivitis, we prefer a erythromycin drops 4 times a day for 2 to 3 weeks. Oral erythromycin syrup of 50 milligram per kg per day in 4 divided doses for 2 to 3 weeks can be given. And evaluation of systemic involvement is also needed in these patients. If gonococcal conjunctivitis is there, then topical irrigation with normal saline is required to remove the excessive mucopurulent discharge. Ceftriaxone in a single dose, that is 25 to 50 milligram per kg intramuscular or IV up to a maximum of 125 mg can be given. If there is associated systemic disease, treatment is required for 7 to 14 days depending on nature of the invasive infection. Bacitracin or erythromycin ointment every 2 to 4 hours can be given. Hospitalization and evaluation for disseminated Neisseria gonorrhea infection can be done, and topical saline drops are required often to remove the discharge. Also, topical atropine can be added if there is corneal involvement. In HSV keratoconjunctivitis, a cyclovir IV 45 milligram per kg per day plus vidarabin 3% ointment 5 times per day for 14 to 21 days, depending on the presence or absence of CNS involvement, can be started. but always there also has to be a involvement of the systemic condition is seen very often. So it has to be treated with a high dose intravenous acyclovir under a pediatric specialist care. Early diagnosis and treatment of encephalitis, that is if the PCR of CSF is positive in 95% patients, so it may be life saving or prevent a serious neurological disability. Other bacteria like gram-positive bacitracin, for gram-positive bacitracin ointment 4 times a day for 2 weeks can be started. And for gram-negative bacteria, gentamicin, tobramycin, or ciprofloxacin 4 times for 2 weeks can be given. Usually, the prognosis is good if treated well within time and a complete dose is taken by the patients.
So if child comes on say 5th day after birth with a lot of congestion discharge, what will be your flow chart of management? How will you go about?
So first of all, sir, if there is a lot of discharge, we can send the patients for gram and Giemsa staining, standard bacterial culture. Also, we start with an erythromycin on day 1 itself and wait for the arrival of the culture and gram stain results. And the follow-up can be taken on a daily basis to see how much improvement is there. Also on bacterial sensitivity test, whatever shows up, we can we can prescribe antibiotic according to that. We can also send for nucleic acid amplification and PCR and viral culture if that is suspected.
What about medication? What do you start generally?
We can start on erythromycin.
Erythromycin ointment.
Yes, sir.
Any other medicine which is preferred nowadays?
Tobramycin, sir.
Nowadays we prefer more empirical treatment with moxifloxacin drops.
Okay.
Which are also safe for neonates.
Yes.
And for gonorrhea, if it is a proven gonococcal infection on maybe says staining, gram staining, and of course culture. So what systemic dose is given?
Sir, ceftriaxone can be given in a single dose, 25 to 50 milligram per kg, intramuscular or IV. So, based on
Same
whether system, yes,
yeah, same can be given in drops of form also. Ceftriaxone.
yes,
And
sir.
yeah, as here also it is mentioned that saline drops to remove discharge is very important, because
Yes,
many times these babies come with lot of discharge and then the penetration of drug is very less. So you must keep on washing the discharge. So the attendant or mother has to be shown how to wash off the discharge every now and then.
yes, sir.
And these Neisseria are one of those these things, bacteria which can penetrate intact epithelium also. So they
Yes,
can
sir.
have perforations and endophthalmitis very quickly. So we have to be extra careful in these babies.
Yes, sir.
Okay. Okay. Any other questions by anyone? So find out the commonly used medications, oral capsules which are Aquasol A, which are available. Find out the dosage and
Yes,
how
sir.
much has to be given. And generally, if these vitamin deficiency signs are more common in up to 5-6 years of age, after that it's very rare to have. So if you find those in adults, always get a gastroenterologist's opinion, because there can be issue with the liver or intestinal absorption. So
Yes, sir.
adult onset retinal this blindness, night blindness, can one of the causes can be vitamin A deficiency. Apart from, of course, retinitis pigmentosa, but retinitis pigmentosa will have signs on the retina, while generally the vitamin A deficiency will not have any signs in the initial stage of the disease.
Yes, sir.
Also, there are many patients who undergo bypass surgeries like the bariatric surgeries. So they have to be on supplements because many times vitamin absorption gets reduced, even pancreatic surgeries. So all those require preventive, like, or they need vitamin A supplementation apart from other supplements later on. So if they are not taking, that may also lead to adult onset vitamin A deficiency.
Yes, sir.
Okay.
Yes.
Okay. If there are no other questions, then we'll end the lecture. Any questions? Any other?
No, sir.
Okay. Chal. Thank
Thank
you.
you, sir.
Bye.
Thank you, sir.